Hello and welcome to this webinar. Today I'm going to talk about recommendation for immunization of a solid organ transplant and hematopoietic stem cell candidates and recipients. My name is Daniele Donà and I completed my medical training in Padua at the Department for Women and Child Health. During my residency in pediatrics, I developed a strong interest in pediatric infectious diseases, and since my third year, I work intensively with the pediatric infectious diseases team. Let's see now all the vaccinations available one by one. Let's start with influenza vaccine. As you know, immunocompromised patients are at high risk of severe illness and complications compared to healthy patients. Early seasonal influenza vaccine is very important in patients with advanced organ failure because influenza can be clinically severe, predisposing to subsequent bacterial infection and may delay transplantation. Influenza infection can result in severe complications in transplant recipient as well. Importantly, the majority of influenza vaccine trials in solid organ transplant and hematopoietic stem cell transplant recipients have been conducted using exclusively or primarily adult population, so limited pediatric-specific data on influenza vaccine response in transplant population exist. Because of the seasonal nature of influenza, patients are often in the first 6 months post-transplant during influenza season, and there is a concern that they will have decreasing immune response to the vaccine. A review article in 2013 demonstrated that although administering the influenza vaccine the first 6 months after transplant results in poor immunologic response, it was still effective in preventing clinical influenza. A multi-center core study in 2015 demonstrated that the time for transplantation had no association with response to vaccination. In the pre-transplant period, guidelines recommend 1 dose of standard injective inactivated influenza vaccine for all children older than 6 months before influenza season, and this must be repeated annually. All family members, close contacts, and healthcare workers should be annually vaccinated to provide herd immunity. In the post-transplant period, the live attenuated influenza vaccine must not be given to transplant recipients. The one that should be administered is the inactivated seasonal vaccine. For solid organ transplant, current recommendations for influenza immunization are provided by the American Society of Transplantation and by Infectious Disease Society of America. The American Society of Transplantation recommends that influenza vaccine can be given no earlier than 3 months following transplant and intensified immunosuppression, although administration as early as 1 month post-transplantation can be considered during periods of high influenza activity. Similarly, Infectious Disease Society of America recommendations allow for initial administration of influenza vaccine within 2 to 6 months post-transplantation or earlier in case of outbreak. For hematopoietic stem cell transplant recipients, current guidelines for influenza vaccination differ with regard to recommended initiation of post-transplant influenza vaccine. The 4th European Conference of Infection and Leukemia recommends that the vaccine can be given at least 3 months after transplant, with a second dose of vaccine 3 to 4 weeks following the first. In contrast, Infectious Disease Society of America recommends vaccination administration 6 months after the transplantation, or as early as 4 months after transplantation during outbreak. Data regarding the utility of 1 dose versus 2 doses influenza vaccine regimen post-transplant are still conflicting. Unresolved issues with regard to influenza immunization in pediatric transplant recipients are numerous and include the following. We need to understand the optimal post-transplantation timing of immunization, the number of doses required to achieve optimal immune responses, the role of adjuvants, and immune markers of biomarkers to predict successful immune response and protection from influenza. Needs to be evaluated the potential role for intraseasonal vaccination when the first influenza vaccine is given early in post-transplant. And moreover, pediatric studies are needed to determine whether administration of high-dose influenza vaccine is an effective strategy for enhancing vaccine immunogenicity and efficacy. Of the currently licensed vaccine against bacterial infection, pneumococcal vaccination is likely to prevent the largest number of post-transplantation infections. Invasive pneumococcal disease is an important cause of morbidity and mortality in immunocompromised patients, and several studies have demonstrated that adults and pediatric solid organ transplant recipients have greater IPD incidence than healthy children. Recently, population-based surveillance has shown that patients who have received a solid organ transplant or hematopoietic stem cell transplant have a nearly 50-fold increased incidence of IPD compared to the general population, with a case fatality rate between 10 and 12%. So all candidates should receive a PCV13 if not yet administered, and PPSV23 should be administered at least 8 weeks after completing the PCV series, with the aim of coverage of the additional serotype not included in the conjugate vaccine. Current guidelines recommend for both pre- and post-transplant period. Talking about future direction on pneumococcal vaccines, of course we need further information regarding the optimal transplant timing on pneumococcal immunization. It's also important to understand the serotype-specific data and comparison of invasive serotypes between immunocompromised and immunocompetent pediatric transplant patients. Of course, we need also further data to describe the frequency of natural history on pneumococcal nasopharyngeal colonization in pediatric transplant patients. Despite the recent introduction of meningococcal conjugate vaccines, invasive meningococcal disease remains a problem worldwide. Peak incidence of invasive meningococcal disease occurs in 3 groups: infants and children younger than 5 years of age, adolescents and young adults between 16 and 21 years of age, and adults older than 65 years of age. The quadrivalent conjugate vaccine is routinely recommended for transplant candidates as young as 2 months of age, and a 2-dose series given 12 weeks apart is recommended. For the post-transplant period, as for pneumococcal vaccine, for solid organ transplant starting from 2 months and for hematopoietic stem cell transplant starting from 6 months, a 2-dose schedule is recommended. As already reported for meningococcal conjugate vaccine, the meningococcal B vaccine is routinely recommended for transplant candidates as young as 2 months of age. In the post-transplant period, starting from 2 months for solid organ transplant and 6 months for hematopoietic stem cell transplant, this vaccine is particularly recommended in patients with persistent complement deficiency, patients taking eculizumab, and patients with anatomical functional asplenia, or those at increased risk for serogroup meningococcal disease. Future direction for meningococcal vaccines are to define which pediatric transplant recipient will require immunization, and we need studies to define the risk of invasive meningococcal disease associated with functional asplenia to the liver disease-associated hypersplenism. Primary varicella infection in immunocompromised individuals, such as solid organ transplant and hematopoietic stem cell transplant recipients, can be severe, with rapid progression leading to disseminated disease with a multiple organ involvement. Although varicella vaccine coverage rates are reported as high as 93%, pediatric transplant patients remain at high risk for varicella infection and complication due to post-transplant loss or waning of immunity. Varicella vaccine is normally recommended after 1 year of age, but it can be administered to varicella-naive candidates as early as 6 months. Optimally, 2 doses should be administered 4 weeks apart. So current guidelines recommend a 2-dose varicella vaccine approach in seronegative solid organ transplant and hematopoietic stem cell transplant candidates age more than 12 months if they are not immunosuppressed and when the interval for the organ transplantation or to start the conditioning regimen is more than 4 weeks. 2 live vaccines, MMR and varicella, can be administered on the same day. However, if not, the second live vaccine should be administered more than 28 days later. Important to keep in mind is that tuberculin skin test is part of the pre-transplant workup and live vaccines can interfere with the response. So tuberculin skin test can be done on the same day as the live vaccine injection or 4 to 6 weeks later. Intravenous immunoglobulin can interfere with the response to live vaccines, so vaccines should be delayed for 3 months after the receipt of blood products. Due to its live attenuated nature and the possibility of vaccine strain infection, varicella vaccine is contraindicated upon transplantation in solid organ transplant recipients. Although live attenuated vaccines are generally contraindicated in post-transplantation, based on several recent studies that have reported on the tolerability of primary varicella vaccination in seronegative pediatric liver and kidney transplantation recipients, current guidelines make an exception for this patient only if there are minimal or no immunosuppression and we have not a recent graft rejection. Post-vaccination serologic evaluation is a reasonable option pending further studies to evaluate the role of a third vaccine booster dose to ensure sustained cell response and protection in solid organ transplant recipients. A 2-dosage regimen of varicella vaccine is recommended in seronegative hematopoietic stem cell transplant recipients if not on immunosuppression or without evidence of GvHD when after at least 24 months after terminal transplantation. A minimum interval of 3 months is recommended for children aged less than 12 years of age and 4 weeks for children older than 13 years of age. Several existing issues on varicella vaccine should be addressed through further research. Potential exists for multi-center study to identify patients who could safely receive varicella vaccine after solid organ transplant. We need to evaluate the role of third varicella vaccine booster dose to increase cell response and protection in solid organ transplant recipients. New research is needed to develop a clinically validated markers of cell-mediated immunity that would aid to identify the seronegative patients who are potentially protected against varicella. The severity of measles infection in immunocompromised patients is well documented. With decreasing measles vaccine coverage and increasing frequency of measles outbreak, optimizing pre-transplant measles vaccination and understanding the safety of post-transplant measles vaccination is crucial. The MMR is live attenuated vaccine and it's only recommended to be administered before transplant, but as varicella vaccine, it can be administered in selected organ transplant recipients on minimum immunosuppression. MMR vaccine administration in pediatric patients is recommended before transplant as early as 6 months of age, and a second dose will be needed if the infant did not receive a transplant before 1 year of age. All children should complete a 2-dose MMR series more than 4 weeks apart. A study of pediatric recipients of living donor liver transplantation evaluated the safety and effectiveness of MMR vaccination, and the patient achieved seroconversion for the live attenuated strains of measles, mumps, and rubella administered separately, and there was no evidence of infection after the immunization. Due to its live attenuated status, MMR immunization is not recommended post-transplant or within 4 weeks pre-transplant for pediatric solid organ transplant recipients. As for varicella vaccine, measles, mumps, and rubella vaccine should be considered in seronegative pediatric liver and renal transplant recipients on low-level maintenance immunosuppression or without recent history of allograft rejection. Recommendations for MMR vaccine in hematopoietic stem cell transplant recipients are similar to those for varicella vaccine. Measles seronegative should receive 2 doses of MMR vaccine, and administration recommended starting from 24 months post-transplant in patients without active GvHD or ongoing immunosuppression, and from 8 to 11 months after the last dose of IVIG. Hepatitis B vaccine is important for patients who lack anti-hepatitis B surface antibody, because hepatitis B acquisition in the post-transplantation period has been reported, especially in the setting of donor-derived hepatitis B virus infection, as a result of accepting an allograft from a donor with positive anti-hepatitis B core antibody. Moreover, HBV reactivation has been observed in solid organ transplant patients due to immunosuppression. The 3-dose HBV vaccine series 0, 1, and at 6 months is most commonly administered to seronegative patients, although the third dose may be given post-transplantation if the transplantation occurs in the interim. Accelerated regimens at 0 to 1 and 2 months or 0, 7, and 21 days have been advocated by some clinicians in order to complete the series before transplantation. However, physicians should be aware that transplantation candidates, especially those with liver cirrhosis who receive the accelerated hepatitis B vaccine regimen, have lower vaccine response rates compared with those without liver cirrhosis. Furthermore, it is recommended that the fourth HPV vaccine dose should be administered at 12 months in patients who undergo to accelerated vaccine series. In pre-transplant period, post-vaccination anti-hepatitis B surface titers should be obtained and the second 3-dose series should be administered if a target titer more than 10 unit milliliters is not attained. Combined hepatitis A and hepatitis B vaccine can be used for transplant candidates aged more than 12 years of age in whom both vaccines are indicated. In the post-transplant period, for solid organ transplant recipients, wait at least 2 months per transplantation, complete vaccination series started pre-transplantation, and check and recheck vaccine titers to ensure ongoing protective immunity. For hematopoietic stem cell transplant, 3 doses starting between 6 and 12 months after transplant are recommended. But also in this case, we need to check and recheck vaccine titers to be sure that you have a protective immunity. Hepatitis A vaccine should be considered in all seronegative organ transplantation candidates, but given the increased risk of severe hepatitis infection in patients with underlying liver disease, it's particularly important in liver transplantation candidates. Hepatitis A virus vaccine is recommended before liver and intestinal transplantation and is an important vaccine for foreign travelers. Solid organ transplant patients need 2 doses of vaccine to have an adequate body response. The seroconversion after 1 dose of hepatitis A vaccine in solid organ transplant recipients was found 41% in liver and 24% in renal transplant recipients respectively. But when a second dose of vaccine was received, the data show that their seroconversion increased to 97% in liver and 72% in renal transplant recipient. In some cases, a booster dose can be considered because the antibody response has been shown to wane by 2 years post-vaccination in solid organ transplant population. During last years, an increase of hepatitis A infection has been reported worldwide. WHO estimated hepatitis A caused approximately 11,000 deaths in 2015, accounting for 0.8% of the mortality from viral hepatitis. One way for transmission is by family members traveling to endemic countries, and for this reason it's important to vaccinate even the relatives of patients who is candidate for transplantation, especially if they travel to endemic countries. In solid organ transplant recipients, hepatitis A vaccine can be administered from 2 months after transplant in seronegative patients. It can be started after transplantation or can represent the completion of a series started pre-transplantation. In some cases, a booster dose can be considered because the antibody response has been shown to wane by 2 years post-vaccination. In hematopoietic stem cell transplant recipients, hepatitis A vaccine can be administered from 2 months in seronegative patients, with a second dose after 1 year from the previous one. As you well know, recently I've been reporting an high prevalence of pertussis among adolescents and young adults, secondary to the waning immunity of vaccine administered during early childhood. Diphtheria, tetanus, and pertussis vaccine is recommended to be administered before solid organ transplant because it's safe and immunogenic in patients with end-stage organ disease, and because transplant recipients' response to pertussis vaccine may be unreliable post-transplant. Usually, DTaP is administered with 0, 1, and 6 month schedule with hepatitis B vaccine, polio, and each flu type B vaccine. While for the first schedule DPAT is recommended, for booster doses Tdap is usually indicated. Only few studies have assessed pertussis seroprotection and vaccination in pediatric solid organ transplant recipients. In a study from the Swiss National Reference Center, only 43% of patients presenting to the center for pre-transplant evaluation were up to date to the age-appropriate number of DTaP vaccines. Talking about post-transplant immunization recommendation, for solid organ transplant, wait at least 2 months post-transplantation. Complete vaccination series started pre-transplantation, and then check and recheck vaccine titers to ensure ongoing protective immunity. Solid organ transplant patients should receive a tetanus booster 5 years after last administration, and the inclusion of pertussis component is very, very important, as pertussis is like an unrecognized cause of morbidity in transplant recipients. In hematopoietic stem cell transplant recipients, vaccination with pertussis-contained vaccine is recommended as early as 6 months post-transplantation with a 3-doses regimen. And due to the naive states of stem cell transplant recipient with regard to vaccine status, current guidelines suggest that consideration should be given to the use of DTaP preferentially, as opposed to Tdap, regardless vaccination received before and patient age. This recommendation is supported by adult data demonstrating poor pertussis seroconversion in adult recipients following Tdap immunization. Human papillomavirus is a double-strand DNA virus that has been known to possess oncogenic potential since the 1970s. The connection between cervical cancer and HPV was made in the 1980s, and since then about 12 HPV types have been identified as a high risk due to their oncogenic potential. In addition to cervical cancer, HPV acquisition is linked to other anogenital cancer as well as oropharyngeal cancer. While the overall risk of cancer in solid organ transplant recipient is increased, the relative risk of HPV-related cancer in transplant recipients, and particularly pediatric transplant recipients, is not clearly defined. Impaired tumor immunosurveillance may predispose to increased risk for malignancy following acquisition of oncogenic HPV genotypes. Thus, although development of HPV-associated cancer occurs primarily in adults, HPV vaccination of pediatric transplant patients may be critical intervention for decreasing overall malignancy risk in this population. Current guidelines emphasize the importance of completion of the vaccine series prior to the transplant. There are currently no studies that demonstrate the post-transplant durability of pre-transplant HPV vaccine-induced immunity in either adults or pediatric solid organ transplant recipients. In addition, no studies have addressed the efficacy of pre-transplant HPV vaccination in preventing post-transplant HPV acquisition or HPV-related precancerous lesion or malignancy. Quadrivalent vaccine is recommended for use in males and females 9 to 26 years of age. This vaccine can be given regardless of history of sexual activity, and a 3-dose vaccination schedule 0, 2, and 6 months should be given prior to the transplant. As post-transplant indication for solid organ transplant, as for other non-live viral vaccines such as Hepatitis A and Hepatitis B, HPV may be administered post-transplantation if the transplant recipient did not complete the series pre-transplantation or remain seronegative despite the previous immunization. In hematopoietic stem cell transplant, a 3-doses regimen is recommended starting 6 months after transplant. The rotavirus vaccine has not been studied well in the transplant patient, but at this moment the vaccine is not listed as a contraindication because there is no reports of vaccine-derived rotavirus infection. If an infant in the transplant recipient household received the vaccine, the transplant recipient should avoid contact with diapers and stool for 4 weeks after each vaccine administration.